Hello everyone, we are here today to discuss the effectiveness of lower limb orthosis for injury prevention. For the background of the topic, a lower limb orthosis is an external device applied to a lower body segment to improve function, usually by controlling motion, reducing pain, or correcting flexible deformities. The knee is the largest joint in the body and in exposed position makes it vulnerable to injury during athletic activities. Patellofemoral pain syndrome is the most common disorders of the knee. It is usually treated non-operatively with an exercise rehabilitation program. 7 to 40% occurs in young adults and it occurs more in females. The goals of treating PFPS is reduce pain, second is prevent muscle atrophy, and third is improve functional capacity. The study design of all 4 articles that we will be discussing are quantitative based on data, analytic based on objectives, and experimental based on methods.
For the first article, the effect of bracing on patella alignment and patellofemoral joint contact area. For the methodology, 15 women between the ages of 18 and 43 years with the diagnosis of patellofemoral pain participated in the study, and only women were studied because of the higher incidence of patellofemoral pain in this population and the potential biomechanical differences between sexes. Assessment of pain response using a visual analog scale. Subjects underwent axial plane magnetic resonance imaging of patellofemoral joint. Measures of medial-lateral patellar displacement and tilt and medial and lateral facet contact area were obtained from the magnetic resonance images. Imaging was done with knee extensors contracted under 3 conditions: no brace, on-track brace, and patellar tracking orthosis. For the situational analysis, comparison of pain response between conditions with and without a brace was made using a one-way ANOVA with repeated measures. For the results, on average, the on-track brace reduced symptoms by 50%, whereas the PTO reduced pain by 44%. When averaged across all knee flexion angles, the PTO and the on-track brace significantly increased total patellofemoral joint contact area by 52 mm and 59.3 mm respectively, when compared with no brace condition. Bracing had no influence on lateral patellar tilt. However, small but significant changes in lateral patellar displacement were observed. For the second article, the effectiveness of patellar bracing for treatment of patellofemoral pain syndrome. For the methodology, 129 patients with PFPS subjects, 57 males and 79 females. Baseline assessments were performed on all subjects including knee function and pain ratings for 3 situations: knee pain during sport activity, knee pain 1 hour after sport activity, and knee pain after sitting with knees bent for 30 minutes. Subjects were randomly assigned to one of 4 treatment groups. First, for home exercise program, second for patellar bracing, third for home exercise program with patellar bracing, fourth for home exercise program with knee sleep. Measurements were repeated at 3, 6, and 12 weeks. Measures of outcome was pain and knee function. For the results, for pain, there was a significant reduction in pain in all groups over 12 weeks, but no difference between groups. For knee function, there was a significant improvement in knee function in all groups over 12 weeks, but no difference between.
For the third article, efficacy of prophylactic knee bracing in high school football players. For the methodology, 524 starting players from 8 high school football teams comprising of boys aged from 16 to 18 years with no prior knee injury. Exposure criteria were developed to capture all potential exposure to contact a football player would experience throughout the football season. The number of exposures to contact, the number of knee injuries in practices and games were recorded by certified athletic trainers. The mechanism of injury was also recorded as either a direct contact to the knee or non-contact injury. Braces was required by the coaching staff in 3 high schools. However, use was voluntary for the other 5. For the situational analysis, chi-square analysis were used to compare the following: number of injuries in braced versus non-braced knees, mechanisms of injuries, and types of injuries, both major or minor. For the results, in the brace group, there were 21,640 exposures to contact and 23 injuries occurred. In the non-brace group, there were 19,484 exposures to contact and 26 injuries. There were no differences in injuries occurred between the braced and non-braced group. The mechanisms of injury were categorized as contact versus non-contact, and there was also no statistically significant difference between contact versus non-contact mechanisms of injury between the braced and non-braced groups. For the last article, home-based exercise and patellar bracing in the treatment of patellofemoral pain syndrome. For the methodology, a total of 86 patients with PFPS were included in the study. Patients were randomized into two groups. Group 1 received a home-based exercise program only, while Group 2 received the same home-based exercise program along with a patellar brace. To identify PFPS from normal knee pain, this study used Clark's test, patellar comprehension test, patellar apprehension test, and palpation of the medial border of the patella. Outcome parameters were pain and functional capacity, discussed through VAS and WOMAC for pain, and FSP and WOMAC for functional capacity. All were scored through Likert scale. The means and standard deviations were given as descriptive statistics. For determining the difference before and after treatment for all groups, the non-parametric Wilcoxon test was used. In order to compare the difference between the groups, the Mann-Whitney U test was applied. All analyses were completed by using the software program for Windows. For the results, all patients completed the regular exercise program. They did not report any adverse events caused by the exercise program or the brace at the end of the therapy. After the therapy program, there were statistically significant decreases in both the VAS and the WOMAC pain scale, while we found statistically significant improvements in the WOMAC functional capacity for all patients. Now for the overall conclusion. Lower limb orthosis may minimize lower extremity injuries, but their true effectiveness remains debatable. The current situation is one of confusion among players, coaches, parents, and especially physicians about when knee braces should be used. Bracing can be an effective conservation treatment for decreasing the symptoms of PFPS. Currently, there is no optimal type of bracing for all patients since multidimensional aspects like psychological and biomechanical have been proposed to reduce the symptoms of PFPS with different types of bracing. Prior to choosing a brace, it is essential for practitioners to understand previous injury, pain history, and physical activity for each patient in order to create an individualized bracing treatment. Thank you!